delighted that you're here. We're even more delighted that we get to hear the relatively new director of the Center for Bioethics and Social Sciences and Medicine speak with us today. I am seriously tempted to say that Dr. Reshma Jagsi needs no introduction and just sit down. But let me say a few words. You may not know who Dr. Jagsi is. She did her medical training at Harvard and also completed a fellowship in ethics at the Center for Ethics at Harvard University. She completed a doctorate in social policy at Oxford, and she served as the director of the ASCO, the American Society for Clinical Oncology Ethics Committee. So she comes to us with substantial experience. She is the radiation oncologist in clinical medicine, but also in ethics. Perhaps the best way to pass the floor over to her is to just and caring human being who tries to deliver quality and ethical care to patients here and elsewhere. So please join me in welcoming Dr. Jackson.
Thank you. It's really a delight to be with you here today. And the topic of our discussion is going to be a little bit off the beaten path. We're going to talk about ethical issues related to fundraising from grateful patients. And so I recognize some of you in the room. So how many of you are actually development staff or administrators? So we've got a pretty good representation from the development community. And then how many of you, and I should have said development professionals, I'm sorry, development professionals or administrators. And how many of you are clinicians? So really kind of an even balance in the room today. And how many of the clinicians in the room, put your hands back up if you're clinicians. How many of the clinicians in the room have interacted with professionals? And how many of you have been asked to participate in fundraising for our institution? And how many of you fundraising for our institution? Okay, excellent. So we'll talk a little bit about some of the ethical issues that arise in this context. So fundraising from grateful patients has multiple societal benefits. Philanthropic contributions are absolutely essential in ensuring that hospitals and academic research, our mission as an academic medical center, is adequately funded. And contributions to academic medical centers are increasing from the AAMC. The rate of increase was 16.2% in 2013. This is particularly critical in the modern era. We're all aware of tightening governmental budgets for funding of research and lowering reimbursements for clinical care that are really putting academic medical centers in a pinch. And therefore, grateful patient contributions are perhaps today even more so than in the past an important source of revenue. And donations from grateful patients are quite substantial. Even in 2009, they totaled nearly $1 billion. course, donating, the act of donating, may benefit patients themselves. This can be quite empowering for a patient or family to actually be able to give back, to join the fight against a disease that afflicts them or someone they love. And we know from social psychological literature that the exercise of altruism might improve well-being, but less is known about whether simply giving money leads to that improvement in well-being, or whether it is that more active volunteering giving of time, which is what's been documented more in the psychological literature. So there's really an open area for research here. Now, physicians play a key role in grateful patient fundraising. The development literature is actually full of articles that identify physicians as an important resource in identifying and soliciting donations from grateful patients. Physicians obviously have a close relationship with potential donors, and their involvement has been documented to increase the frequency and size of donations. Now, the cynical in the audience might say that the reason that the involvement of physicians increases the frequency and size of donations is because they wield undue influence, and that perhaps their involvement is inappropriate. But I think that together what we need to do is figure out ways that physicians can be involved in ways that patients, society, physicians, development professionals, all of us would agree are appropriate and are beneficial to not simply the institutions in society, but also protect the rights and interests of patients themselves and the physician-patient relationship. So a couple of years ago, we actually decided to study this, and the paper that we published actually led to a really nice article in the New York Times. A new effort has doctors turn patients into donors, and a lot of people told me they read that article thinking we were talking about organ donation, and I'll leave it with you that actually there may be some parallels between organ donation and donation here. But this was a wonderful story of a couple from the University of North Carolina who donated money for research. And it's really nice to read their story. So actually what it says here is that they gave $2 million for research and an endowed professorship in radiology. So they actually were initially thinking scholarships. So you can see that. And they donated to radiology. And I just say, like, radiation oncology is probably not the most sexy discipline, but radiology, diagnostic radiology is probably like even less exciting. They donated to a radiology professorship. They committed their entire estate. And I think this is really inspiring because they were going to give to something that they thought was meaningful. And by talking with development professionals, they actually decided that they were so grateful for the care that they received for cancer that they wanted to donate to healthcare. Now, I think that's generally a good thing. The football fans in the room might think that we shouldn't be siphoning off money from the athletic program, but you know, this is not a bad thing that we're seeing here. And so here's another example of an oncologist, Lisa Carey, whom I happen to know because she's actually a breast oncologist at UNC. And so these are individuals who actually sat down with their physician and had a conversation prompted by the development office, and they were actually asking what she needed. And she said, well, she needs money for research and to help other patients, and actually admitted, I'm not very good at this. If you know Lisa Carey, she's the most articulate talking about breast cancer clinical trials. So to hear from this incredibly articulate leader in the field that she feels she's not very good at this suggests that perhaps there is a role for helping physicians understand how to navigate their role in this circumstance. And it's really nice, this story. So the patient asked if she thought they could make a difference with a donation, and then they went home and made an even more generous donation, 10 times the original amount. It's something that says, I appreciate what you do. I know it will be well spent. But there are, of course, ethical implications to all of the activities that we undertake when we seek to raise funds from patients. First, there's the process of identifying patients who have high giving capacity. And institutions actually vary occurs, who identifies wealthy patients and how it's done. Approaches do include formal wealth screening programs that actually look at publicly on tax records and home value prices, your address, things that you might provide even before you walk in the door as a patient. It may be that you've been wealth screened. To causal inferences that are drawn by a treating physician who might hear that you mentioned that you have a second home or that you're independently employed. Information that you may not have provided to that physician with the intention of being wealth screened, but actually information you provided in the course of delivering routine clinical care that you intended to be used in ensuring that the care you received was tailored to your particular individual situation and social circumstances. Another activity that goes on is the initiation of the conversation about philanthropy. So it's easy enough if the patient directly actually brings this up themselves organically and expresses a desire to give back. But how a patient does to a development training very early when I joined faculty that actually inspired my research in this area, where we were counseled to view a patient who brought us a plate of brownies or cookies. Scott, you may remember this, right? But if the patient brings you a plate of brownies, don't just say thank you. Say, do you want to? And I remember thinking, the patient who not necessarily the person that I feel comfortable saying, well, that was really nice that you brought me the cookies. You want to hear something else you can do? It really rubbed as from this particular development professional who was a trainer for a very large company that provided these trainings. He viewed this as an indication from the patient that they might from the patient that he or she is grateful. But taking that next step made me feel very uncomfortable personally. And there can also be indirect overtures where physicians might say, would you like to hear more about my research, the exciting things that are going on in our department? And different physicians feel differently about whether or not that's appropriate, when it's appropriate, in what context. There are distinct roles of the development professional and the physician, and some institutions actually clearly define these roles, stating which actions the development professional will handle and what's expected of the physicians, but many other institutions leave this to the individual development professional. There is then the process of relationship building, also known in the development community as cultivation. It's a process that takes place over time, often years. Methods are diverse, encompassing face-to-face interactions with patients, oral, written, and other modes of communication, and involvement of institution leadership, sometimes including the treating physician at key points. Then there's perhaps the most difficult point, which is the actual solicitation of a gift. And because this activity arguably some development professionals actually state their job and not the physicians, but others do allow or even encourage physicians to solicit directly. And there's an example of a very, very successful surgeon who is renowned and certainly looked upon in high esteem by after he operates on a patient, is known to go in the immediate post-operative visit after the patient has recovered from anesthesia, but the next day when the patient is conscious and awake but still feeling very grateful. And so, I have now cured you of your terrible condition X, and you're feeling pretty thankful to me right now. And you know how you're going to pay me back? You're going to write me a check, and we're going to help a whole bunch of other patients who might not have access to the care that you do. He's trying to do a good thing. He's trying to actually build a patient tower to help other patients. But he's using his influence. And I mean, and that is actually, that's been recounted by others who've observed it, exactly the way he approaches it. And he's a charming guy. And again, held in high esteem. And so he gets away with it. But the question remains, is that an appropriate time for him to be soliciting a gift? And is that the appropriate manner? Stewardship that occurs after the gift is all of the activities that manage and sustain the relationship with the donor, ensure that the donor's wishes are respected, but also ensures that the money is put to good use and is appropriately stewarded. So there's actually really limited conduct in this context. So the AMA has a very brief statement from the Council on Ethical and Judicial Affairs that was put out back in 2004. And it discourages physicians from direct solicitation of their own patients, especially in the context of clinical encounters, but doesn't go so far as to prohibit it. There are many challenges in this context, including physicians' conflict of obligations, because of course we have an obligation to our institution and to other patients who might come before us in the future, but also to the patient before us. There's the issue of patient vulnerability. It's often said that we shouldn't approach patients who are vulnerable, to which I've asked, exactly which patients aren't vulnerable? Aren't we always in a situation of power? Aren't patients always, when they're in the context at least of a clinical encounter, in a somewhat vulnerable position? I have that patients, especially wealthy patients, view physicians as functionaries. I happen to have some very wealthy relatives and their friends, and I do understand that they may view physicians in a different way than perhaps others. You know, if your hairdresser asked you for money, you wouldn't feel like you were vulnerable, and yet you really care how your hair turns out. That may or may not be true. We may or may not be held in perhaps a slightly less privileged position than we are in society more generally if the patient is extremely wealthy. But I would argue that when even a wealthy individual is ill or considering his or her own health or mortality, that person is in a position of vulnerability. There are both confidentiality and privacy concerns. So when individuals share information with physicians, as mentioned, they are not usually doing this with the intent to other individuals in the system whose goals are not to provide clinical care, but actually to raise funds for the institution as a whole. There are privacy concerns because when one comes to an academic center, and this is a concern that's raised by wealthy patients, they may not want the institution to be searching publicly available databases to find out if they have the means to contribute or not, and they may feel violated and feel that their privacy has been violated, even if this is technically publicly available data. There are equity concerns that relate to VIP treatment or donor facilitative services. So what is appropriate to provide to patients? So there are institutions that have special wings or suites that they provide that have better hoteling amenities. I remember the Phillips House at Massachusetts General Hospital, where I was a student and a trainee. Phillips House was at the top of the Ellison Tower. And we used to joke as house officers that the irony was that the patients on the Phillips House, who had these beautiful wood paneled private rooms and a view overlooking the river in Boston, they were actually the furthest away from our call room on the 12th floor. And so actually got the worst possible medical care because if they coded, we were climbing up 12 flights of stairs to get to them. But the concern is that patients who are in those rooms might actually have better access to care. They're certainly labeled as different. Even something as simple as giving them a fancier bathrobe or slippers to wear in the hospital marks them as different, and they may receive different treatment and services as a result. And we do know that having attention paid to one in the context of a medical encounter is critically important. There are also concerns about donor hospital, and so this is a hard hospital to navigate. And so on the one hand, perhaps if someone is care for many other patients who couldn't receive it, degree of hand-holding and facilitation. But the question is where that starts to cross the line and to affect the ability to actually receive high-quality care and actually leads to disparate treatment of different individuals in the context of medical care. And then, of course, there's worry about the impact on the physician-patient relationship. Trust. We do not wish to violate patients' trust. We do not wish to say to a patient in a difficult situation, in the wrong way, something that makes them believe that we don't have their best interest in their health at heart. And so there's a story that was recounted by a patient advocate who these issues, and he recounted a situation had just completed a fairly uncomfortable screening examination, a digital rectal examination. And the physician then, while he was still in his journey, realized that he's from a very wealthy family and said, how you and your family might be able to contribute. He felt so improperly treated, and that trust is gone. That relationship is shattered. He's been seeing that physician for years, but he felt he was standing there in a giant. I mean, you could have picked a better time, right? And so there's worries that doing this the wrong way can actually jeopardize something that's really sacred, the physician-patient relationship. And I don't think that this physician meant to do this. I think they were trying to do something good, but just absolutely bungled it. So this is an extraordinarily important issue. So I was pretty psyched that Arthur Kaplan gave a really nice quote saying that he'd actually never seen a paper that examined the issues as thoroughly as a long overdue discussion. And again, he ticks off these same pitfalls. Patients may be emotionally vulnerable. Doctors have very close ties to their patients, which can strain asking on both sides. And the fact that incentives to ask sometimes skew towards the doctor's own program rather than the most needy areas of the hospital. However, the practice of soliciting is happening, and all signs are that it's going to continue and that it will increase. So Joe Carisi had led a couple of studies at Hopkins looking at patient donations. And so this is very important. They actually did two studies. They did an interview study of 20 physicians who had actually been very successful at fundraising, and a study of 20 patients who had donated substantially to their institution. And they did not observe in those two samples many concerns about vulnerability. These were, of course, patient donors and physicians who felt comfortable participating. But those studies didn't include sort of the typical physician or the typical patient who might not have the means to contribute. And so I think that there are ethical ways of seeking donations for patients who have the means and want to give back, but we do actually need, as a first step, to really understand what physicians are being asked to do and create standards that we can all be comfortable with. So let me tell you about, first of all, what the law allows. So there were 2013 revisions to the HIPAA privacy rule that actually permit development professionals to access certain types of health information for the purposes of grateful patient fundraising. These include name, address, other contact information, age, gender, date of birth, dates of clinical encounters, treating clinicians, departments of services, health insurance status, and outcomes of care. So I was the development professionals in the room who've worked with me realized that I was actually really surprised with this. I said, really, you can know that a patient came to me for treatment because pretty much all I treat is breast cancer. Patient came for me for treatment, you know their diagnosis. You can know their outcomes of care? Really? A privacy rule. And there was actually relatively, they did put this out for public comment, and there was relatively limited public comments. Now, of course, I wonder if that was because not very many people actually heard of this. I was studying this. I didn't hear of this until after it had actually been important. Wealth screening is therefore something that is legally permissible, and Leadership Council, it is routinely used by 97% of healthcare institutions to identify potential donors. The concern is that this may jeopardize patient trust. This is something that I don't think that much of the public or patients are aware is going on. Even as a clinician, I wasn't aware that this was going on until I began studying this issue. And so I think, there is some value to transparency. If what we're doing is right and it's ethically justifiable, then we should talk it's ethically justified and not do this behind closed doors, because otherwise, when people find out, they feel violated. They feel their trust has been violated. So I think we have to really think about ways we can do this thoughtfully together and be transparent about what it is that we're engaged in and why it is important to help patients, to help society, to help institutions, and why we think that justifies what we're doing here. Donors often expect and receive special, but others include personal phone numbers of physicians, in-clinic or inpatient visits from along with additional visits from their treating physicians. And so those are ones that start to become more concerning beyond the coordination of care and the hoteling amenities that I've already mentioned. said, there's only been 4 studies identified in literature that have evaluated patient or physician perspectives on the ethical issues related to grateful patient fundraising. 3 were conducted with physicians. One is the one I'm going to show you, which is our study that prompted that New York Times article. It was a survey study of 405 oncologists, and it was oncologists who were identified across the board from lists of publicly available information of who was practicing at the time 41 comprehensive cancer centers that were NCI comprehensive cancer centers. The other was that 20 physician interview study from Hopkins that actually led to 2 publications, so it counts as 2 studies, but it's one cohort of 20 physicians. Again, their number of donations was something like 30. They had successfully solicited like 30 gifts. That was the mean number of gifts that they had solicited. So they were not the typical physician. They were very successful fundraisers. And then there was one patient study from patient donors. To our knowledge, based on a literature review that was done in June of 2017, there is absolutely no empirical research with non-donor patients, nor with the general public. And so I find this surprising because, we studied this several years ago. I kind of thought somebody else was going to kind of take this ball and run with it, and really no one has. So I'm back to talking about it, and actually, because apparently very few others are. So let me tell you a little bit about that JCO papers. To describe the experiences and attitudes of medical oncologists about their exposure to and participation in philanthropy at comprehensive cancer centers. We sought to determine whether respondent characteristics such as experience or gender were associated with services that were offered to donors or potential donors at these cancer centers by asking these individuals if they were aware of services being provided to donors at their institutions. We found, we hypothesized that a non-trivial proportion of oncologists would report having solicited their own patients for donations. We believed that physicians' behaviors and attitudes would vary by gender, and we suspected that behaviors and attitudes might also vary by years of experience, time spent in clinical practice, and characteristics of their comprehensive cancer center. So this was a cross-sectional study. Again, it was medical oncologists at the 40 National Cancer Institute designated comprehensive cancer centers that treated adult patients in 2012. There was also a 41st center, St. Jude's, in 2012, but we excluded because they treated only pediatric patients, which we thought might be distinct, and the interactions between and providers being different. And we focused on oncologists because we knew that oncologists have a longitudinal relationship with patients who confront life-threatening illnesses, and we believed that these activities were going on. We had actually written a thought piece that we sent to the New England Journal, which was sent back to us saying, why do you think this activity is going on? Where we don't want to hear what you think about the ethics of this until you show that it actually occurs. And that's what really inspired us to do this work. And so what we first did was we reviewed the literature, which was actually primarily limited to the development literature. So there's a lot of good literature in the development literature about how to effectively raise grateful patient donations, less about how to ethically do this, but really good literature on activities that are going on. So we were able to define key constructs in that way. We discussed this with experts. We conducted cognitive pre-testing to improve the validity of our measures, and then we mailed our survey to 771 medical oncologists at their cancer center addresses with a $20 cash incentive. And I will say to the development professionals in the room that that $20 cash incentive came from my startup funds. And in some way were made possible, though not directly from a patient donation, but the fact that patients made donations probably made my department chair then able to save some money and set aside some clinical funds to give me a startup package. And so, I think that what's interesting about this study is that although it wasn't directly funded by a patient gift, it shows that the kind of work we do is sometimes not easily funded by a particular funding agency. I'm not sure who I would have gone to at the time for funding for this. I do have a grant in now to the Greenwald Foundation to see if we can study patients in the public, because I do think there are some donors who and some. There is important research and pilot research, right? I could have gone to the Greenwald Foundation then because I didn't have any pilot data. New England Journal didn't even think this was happening. So I needed to get some data. And so, this is one of the wonderful things that we can actually do thanks to patients. I sent follow-up reminders using a modified Delta 405 responses, so a good response rate. Our measures included when, how, and how often the responding physicians were exposed to fundraising staff at their institution, what subjects were covered in their trainings or individual sessions, their experience with different fundraising activities, and their attitudes related to participation in philanthropy. We also asked about services they believed were provided to patients who donated or were potential donors, their time in practice or percentage of working time spent in clinical practice, and their gender and race. So we had a 52.5% response rate. You always have to worry in survey studies that the individuals who respond to your survey might be from those who did not respond. I will say that for an oncologist survey, oncologists are routinely multiple $100 conditional incentives. This was a non-conditional cash incentive, a guilt incentive, about 1/10 of what they're usually offered. And response rates are actually usually considerably lower than 50%. Possible that those who were more likely to have been exposed to fundraising staff or had stronger feelings about this were more likely to respond to this survey. We certainly did find that the proportion, what one does to sort of evaluate this is see whether there are certain characteristics that you know about non-respondents that are different amongst respondents. And we did find that the proportion of respondents than non-respondents, and it may be, as I'll show you, that female physicians may feel particularly uncomfortable in this context, and so perhaps they were the ones who were more likely to respond. Most of the respondents were white and male, which is typical of medical oncologists practicing at comprehensive cancer centers. So you can see here the sample characteristics. So we did have a majority of respondents being male and white. You can also see that we had a good distribution across the cancer centers. So if you looked at the percentile of their core grant size, we didn't just have the top tier cancer center oncologists responding or the bottom tier. We actually had the large cancer centers and the smaller cancer centers all represented. There was a distribution where we had, a quarter of our individuals who had less than or equal to 5 years of practice, but then sort of an even distribution going up to those who had 21 or more years in practice. So again, a pretty good distribution across years of practice. And also when you looked at their were primarily probably focused on administration or research, spending only less than or equal to 30% of their time or a day and a half a week in clinical care. About half of the respondents were spending kind of what a typical practicing oncologist at a comprehensive cancer center will do, which is between 31 and 70% of their time. And then there were about 1 in 5 who were spending the majority of their time seeing patients, over 71%. So of these respondents, 71% reported that they had been exposed to fundraising or development staff. 79% had been contacted personally by development staff. And 41%, had contacted development staff themselves. In terms of exposure to fundraising and development staff, 37% were being asked to work with development officers. Sorry, I'm still recovering from my notes. So 37% were being asked to work with development staff more frequently than in the past, and 35% were more comfortable working with staff more now than they had been in the past. So that's a bit heartening, I think. Responding oncologist behaviors and experience were ascertained by asking individuals whether they had done it, whether they've been asked to do it but hadn't done it, or whether they haven't even been asked. And committee, and so you can see here that many of the respondents had not even been asked to join a fundraising committee. Speaking at a public meeting about philanthropy to my institution, and again, the majority had not been asked to do that, but about a third philanthropy. You can see here that 17% had done that. Another 4% had been asked but didn't do that. Displaying fundraising or development information in the waiting room. Again, 80% haven't been asked, 14% said they had done it, 2% had been asked but didn't do it. Referring names of patients who would be potential donors to the development office had done that. 14% had been asked but didn't do it, and 47% had not been asked. And then finally, and perhaps the most interesting item, directly asking my patients for donations to my institution. So you can see 16% had done it and another 16% had been asked but didn't do it. So about a third had either done it or been asked to do it. In terms of looking at respondent characteristics, there was some association with years that individuals who had more years in practice were considerations for donations. If you looked also at gender, you would see that there was a trend towards significance with male respondents likely to ask, and if you adjusted for all the other characteristics, univariate analysis was significant, but when you put it in a multivariable model, it was just shy of significant, sorry. And then no associations with size of the cancer center, core grant rates, or percent of working. When we looked at other attitudes towards development and gender, you can see here by gender, the attitude of I have a duty to participate in fundraising for my institution. About half of the women and slightly more than half of the men say yes with no statistically significant difference. A duty to participate in fundraising for the diseases they treat. Again, a large majority of both genders, but no gender difference, saying that they have that duty. Worry about talking to my patients about donations might interfere with the relationships I have with them. 77% of the women and 71% of the men. And so I think that's really important for us to keep in mind, this worry. I think physicians can make a unique contribution by participating in philanthropy. Also, it's pretty strong agreement there, 69% and 76% agreeing with that. Yeah, I feel patients feel empowered by donating. Again, strong 80% that there is patient empowerment that goes along with this. So this might be something that benefits patients directly. What about offering certain convenience-related services within the hospitals? Well, there, only 28% of the women and 35% of the men felt comfortable with that. And that can be offered those services. Only 10% of the women and 21% of the men agreed with that. We asked if they worried about a conflict of interest when directly speaking to patients about making donations, and the majority of women, 61% of the men. In terms of believing that there might be negative consequences if they refuse to participate in philanthropy, 1 in 5 women and 12% of men believed that there would be negative consequences for them. So not simply a conflict of obligations, but actually a concern that there might be retaliation or negative consequences if they actually didn't contribute. And finally, the question about whether it is appropriate in at least some circumstances for a physician to initiate a discussion with her own patients about donating to her institution. 52% of women, 61% of men, so that was okay. So with regard to that. So in summary, women appear slightly more uncomfortable talking with their patients about making donations. They appear less trend, but not strictly statistically significant. Women didn't say they were significant relationships or conflicts of interest. That was what we had actually hypothesized would be the mechanism for women potentially being more worried about doing this. In summary, what we found was that institutions are definitely asking physicians to directly solicit their patients for donations. There is variability in physicians' responses to these requests and perceptions on the impact on their relationship with patients. There probably is something going on that's different because, again, have recent contact with development professionals and reported that they believed that the frequency of that contact was increasing. So of course, we all know that there are wings of hospitals that are named after donors that were named after donors who came many, many, many years ago. And this is certainly not something that is new. But I think that the activities that we're seeing here and the sort of deliberate approach to fundraising is something that's new and something that done in an ethically acceptable fashion, because development professionals are professionals who are trained to do this in a way that's not only successful, but actually should be ethically appropriate. And so it's necessary for us to ensure that fundraising activities remain consistent with ethical norms and policies that are embraced by physicians, patients. Regarding patient and public opinion is absolutely critical to inform ethical recommendations in this context. And so I wanted a summit that was hosted by Johns Hopkins this past June on the ethics of grateful patient fundraising, with the goal of describing the primary ethical issues in grateful patient fundraising and offering corresponding recommendations regarding how to manage them. And I was fortunate to be one of the 29 participants. They included individuals from across the U.S. representing the perspectives of bioethics, clinical practice, development, law, patient advocacy, philanthropy, and compliance. The summit proceedings have been drafted. They've been submitted for publication and will be focused on physics. Say, what is, and I said, hey, ethics girl, you want to write this with me? Let's do a study. And she said, absolutely, let's do a study. And we did this study. And we really did think that this would start a conversation and actually lead others to begin investigation. In the absence of that, and start taking it forward again. We need also research of the impact of philanthropic donation on patient well-being. So Sarah Conrath, who's at IU, has done some really wonderful work about the exercise of altruism and the benefits that that gives to the individual. Because I think for many of us, if you tell me that what I am doing actually really might benefit the patient, him or herself, and is an important part of her healing and returning into survivorship, which is what many development professionals assert and believe. If there were evidence for that, I would have a different perspective on this. I would feel much more comfortable considering, in some circumstances, raising the issue of philanthropy directly with a patient when I otherwise feel quite uncomfortable doing so when I believe that the benefits are to others, to society, to the institution, but not to the patient, him or herself. And of course, we need more research regarding the impact of donor status on physician clinical decisions. And so Sarah and I are going to be working on a study that investigates this a little bit further using some hypothetical scenarios. And and again, I think that study will be funded. It's being funded out of her startup this time. And again, something that probably is the result of philanthropic fundraising. So I want to acknowledge Jennifer Walter, who was the lead author on that JCO paper that I showed you. She was an RWJ fellow here. She's now a pediatrician at who is the biostatistician who is the co-author on that JCO paper and led all of the analyses. And Sarah on trying to investigate some of these questions. Jeremy Sugarman at Hawkins, who led with me in this Greenwald grant application, and then a number of other individuals from Summit who will be working together, hopefully, to take this work forward. Thank you, and I look forward to hearing what you think about this and some interesting discussion. Point, thanks, Naomi. I think that in the context of caring for very ill children at the beginning of life, as you do, or caring for adults sometimes who are passing away from cancer, as I do, indeed, providing care, relationship, and supporting individuals cycle of life, right? And that support that we provide to patients is, I think, critical. I think when patients are grateful, they're grateful that we respected their humanity, that we helped them achieve things that were meaningful to them, that we listened to them, that we embraced their values, their preferences, and their priorities and decision making. And so I think that what we as a center do as CBSSM, and what's really unique about us as a center, is that we bring together individuals with expertise in bioethics and individuals with expertise in support of shared decision making. And when we're it really does require that thoughtful, informed support of shared decision making. And so to me, the patients who appear to be most grateful in my practice are the ones who I believe felt that I truly respected them. And so I think the challenge here is then how not to jeopardize that trust and respect that we have in that relationship by introducing this new dimension. But there are times when I actually think that this person does have the means to give, and she is for other charities. And my goodness, she's so grateful for the fact that she herself has conquered cancer. Wouldn't it be wonderful if she were working towards a cure for breast cancer? And yet I need help from my development professionals to help me do this in the right way. So what I found interesting was I had a recent meeting with my development professionals who came to me with a list of individuals that were not listed in order, but were listed as individuals who might have the capacity to give, who had seen me at least once in the last 2 years. And they said, take a look at this list. And, we said, you know, I don't feel comfortable asking these people for money, any of them. I just don't. If you have an event that you need input to plan, that's an educational event about breast cancer, that will be used for fundraising, but something you need someone who's had the perspective of being a patient and who's thoughtful and who's kind and who's grateful. You can certainly tell most of these patients, and I went through and sort of marked off like people who had seen me only once, but you could go to any of these people and tell them that Dr. Jagsi told us that you were a thoughtful person who had important insights and could help us create a program for others to try to raise awareness about breast cancer and help contribute to fundraising in the community. And then maybe if they get engaged in doing that, and again, I have more evidence that devoting their time will actually cause them a direct benefit than I do that giving money will. So I feel okay with asking them to give their time, and not directly ask, but have the development professional say, that Dr. Jagsi said, and it's a compliment. It's a who might be willing to getting involved, and so if you'd be willing to get involved, we'd be grateful for your help. And then if they do get involved, then maybe they'll actually attend the event themselves, and they'll see that actually there is an opportunity to give, and maybe they will decide to give. I certainly don't comfortable saying, this is the really exciting research I'm doing. Don't you think it'd be great if you, hey, look, I have a thing in the New York Times. Why don't you donate to this really exciting research? To me, that seems very self-interested. But there certainly are individuals who feel comfortable doing that. Lauren. Mm-hmm. Want to do the study? Let's do it. Let's do it. We'll do it. Joe? Mm-hmm. Mm-hmm. It's a real conundrum, right? Because on the one hand, you've got the utilitarians who would say, well, if you do move that appointment up and you push them over the edge and that patient then makes the donation, think of all the other patients who will benefit from that. Greatest good for the greatest number. And did you really hurt anyone? But if you really look at this with a more rights-based framework, you do wonder if you're disrespecting those other individuals who've been. And I don't know what the right answer is. What do you think? Mm-hmm. I take some comfort. I take some comfort in the story, the powerful story that's always told to medical students about why you treat every patient the same way, which is the story that's told about the surgical department chair who comes into the ER and has belly pain, and they immediately do a direct admit to the floor because, it's the chair of surgery, and nobody wants to leave him sitting around in the ER in a Johnny, and so he goes up to the floor and promptly bleeds out from his AAA. And if he'd been in the ER, they might have been able to resuscitate him, or they might have gotten that ultrasound sooner. But because he was a direct admit to the floor, he just sort of sat up there in the nice, fancy wood-paneled room and died. And so sometimes jumping to the head of the queue or being treated better, it's also my joke about the Phillips House, where they're furthest away from medical care, doesn't actually improve medical care. But I think that is what we tell ourselves to give ourselves some comfort for the fact that I think we all know that if somebody has our home phone number or has better access to talk to us or can get a test done more quickly, that actually can have an impact on outcome. And so I think that's the deeply troubling aspect of these VIP services, is that everybody says, and often I hear from development officers who talk to me about this, well, we're not asking you to do anything that changes the level of medical care or affects the level of medical care someone else gets. But can't you do a little more for this person without making the other person worse off? And the question is, I'm not sure that you can. Mm-hmm. Right. Mm-hmm. Yep. And that has actually been stated in the CJIS statement as well. So you want to remove it as far as possible from the acute episode of care. The challenge is for those of us, so we didn't ask in this study because we were medical oncologists, so there weren't any surgeons in our study, but the challenge is for individuals who are caring for patients with chronic conditions. So things like cancer, when we're fortunate we're able to turn it into a chronic condition, or diabetes, or these other things where there is an ongoing relationship and not an acute episode of care. So I think it may be more straightforward for individuals who are delivering episodic acute care to say at some point one is far enough out from that episode that it's appropriate to do this. But I do worry that somebody who has some condition worries that they might require surgery again in the future, or list to attend to if they do donate. So I think that potential for treatment never fully goes away, but I agree with you that intuition that the further away you are from the acute episode, the less vulnerable the patient is and the less likely they are to expect that it'll affect their own care directly. Mm-hmm. Like themselves. Yep, absolutely. And so, I mean, I think we can take heart that many wealthy patients actually do make donations that are charitable and are trying to help those less fortunate than they are. But you're right that in terms of wanting them, which does tend to be the case, that then might lead to a direction of resources towards certain diseases or conditions that predominantly affect those who are better off. And I think that's a really challenging thing, because if you're looking for, if funding for research, for example, starts to become predominated by this sort of philanthropic support, then for assuring that the most scientifically rigorous proposals go through, that the ones that benefit most of society go through, versus hewing to the donor's original intent. And we have to be respectful to the donor as well. And I think these are some of the challenges to which I have no answers, but would at least throw out there as well. Mm-hmm. Right, right. Mm-hmm. Mm-hmm. Yeah, so I think most of our focus was on psychological well-being and potentially physical well-being, but you're absolutely right that some individuals may be donating for other reasons. From the perspective of my being the patient's physician, I'm looking after their health defined in its totality as physical, mental, and social well-being. And so, again, perhaps I come at this with too narrow of a physician's perspective. My goal is to make my patient healthier in all aspects. And so if they're part of a family that has pushed the opiate epidemic and they want to rehabilitate their social image, I feel like my duty is to help them. So for what it's worth, I think that is part of health broadly construed. Might feel a little icky, but other comments? This has been a really wonderful. Yeah, yeah. Yeah, so 3% of our, so I didn't show you this data point, but 3% of our respondents said they had been offered a direct financial incentive. So by which, if you flip that on its head, a financial penalty if they didn't raise funds. Again, 21% of the women and 10% of the men were worried that they would face negative consequences if they didn't participate. Often this is sort of a soft thing that's built in, and we have to be very careful when we say, well, we're going to evaluate contributors to a department's mission by saying, if somebody, everybody knows this, if somebody's a really big fundraiser for the department, it is looked at favorably in departmental reward structures, right? We all know that happens. This is the way of the world. But at the very least, I think we have to be very careful about not having direct financial incentives for raising funds from patients. I think we can say, we'll reward you for speaking at the breast cancer awareness hats and high tea for breast cancer fundraising event. That's great. Thanks for doing that. You're speaking, you're providing the physician's perspective. We're not going to reward you for your particular patient making a gift. Because I think that if we make those very direct ties to financial incentives or other kinds of punishments, like we're not going to give you your preferred call schedule or whatnot, that actually then adds to the conflict of obligations and actually, I think, induces improper behavior out of physicians.